Next speaker will be Dr. AbdelRahman Nimeri. He is coming from United Arab Emirates, and he will speak about his experience in single-stage operative management of laparoscopic sleeve gastrectomy leaks with endoscopic stent placement.
Thank you, Dr. Hussein. I want to thank and welcome the Saudi Association of Metabolic and Bariatric Surgery to Dubai, and thank Sultan for the kind invitation. So I'm going to talk to you today about basically what Ali Al-Muntashiri presented without using clips. Just treating leaks by just taking patients back to surgery, no stents, and depending on enteral feeding, which is basically what Ali said initially, except that we don't use any clips. So I want to show you first that all leaks are not the same. I think when you look at sleeve leaks, you cannot bunch them all together. And I want to touch on two things on the sleeve gastrectomy consensus paper and the meta-analysis that Ali showed earlier until it completely actually goes away. So in summary, I think sleeve leaks are not the same. And I think we have to realize that we don't have 10-year data after sleeve gastrectomy. This is the reality. It's very common, it's done very common, but there's no 10-year data yet. I think enteral feeding is the cornerstone. Whether you do endoscopic stenting or you do operative management, the patient has to have enteral feeding, not TPN. And again, at the end, I showed you that we can actually treat these without having to do stents just by a simple operative strategy, and patients do fine. Thank you so much.
Questions? Okay.
I have a comment about the issue of the sleeve leak. The leak is two parts, not only one. One is the collection and one is the hole. If you speak about the collection, all of us will agree we need to drain, surgical or percutaneous. The hole, you have the right. You could leave it by secondary healing, or somebody could clip it, or the third could put a stent. But we cannot say the stent will not heal, and we cannot say the clip will not get the patient aseptic. No, this is two different parts. So most of the time, when the patient comes with the leak, first target the sepsis to be off, and the nutritional, that's the best. Now leave the hole. You'd like to fix it quickly, put stent clips, or leave it, it will heal by itself, because stomach is a high vascular organ, and as long as there is no twist or obstruction distally, it will heal. Sure. But it will take time.
Sure. Thank you very much. When you go and operate on those leaks, do you attempt putting a Graham batch on them?
We haven't. We actually
mental batch.
We actually don't. So our strategy when we start is the first thing we put the jejunostomy tube before doing anything, because our plan is to put enteral feeding. We don't go digging looking for the leak very aggressively, because it is actually a very angry area, as you know, and you can actually get in trouble trying to do that. So what we do is first put the J tube, then we clamp the ligament of Treitz, do the endoscopy. After we free up the omentum with the suction only. Just use the suction in your grasper. And I don't close the hole. I don't try to do a gram patch, because the area is very angry. If you try dissecting that area, you could actually do more harm than good. So what we do is just with the suction and the grasper, try to separate things gently. And once you separate the omentum from where the sleeve is, you'll have an area that looks very angry, but you can't see anything. In one patient, the leak was actually at the first and second firing. And it was like a big hole. That hole you would not see unless you go into surgery. Once we separate the omentum, there's a huge hole, and you can see staples around it. And that healed by putting a T-tube in it. But we don't actually, our plan is not to go dig into that area near the G-junction, because you could injure the esophagus. I'm very comfortable operating near the esophagus, but in these cases, I can't tell anything.
But most of the cases.
Thank you. Can you? It's enough. Can I have Dr. Bukhari, please?
Thank you very much. All the presentations were very nice, but I have just a little comment. People who work in private, they are limited by the economic status of the patient and the ability of the patient or the insurance to pay the cost of such prolonged care. I've seen in your study that the least one of them took 4 weeks for that to heal. If we have applied the same program that you are all following, guys, and it costed, the minimum cost of one patient was 600,000 riyal to stay in the hospital with the recurrence of infection, with the ICU care, taking care of septic problems, renal dysfunctions, and so on. So we found that, and this was approved in our experience, leak type 1 or 2 or even type 3, which is recurrent long-term leaks, where you find an acute state over chronic established fistula. The best solution, in my opinion, and in our result, and we have a huge number of taking care of leaks, our own and referred from outside, was to do an efficient esophagogynostomy for those cases, and it takes around 1 week for them to stay in the hospital post-heal. And I agree about the point of checking the pre-albumin prior to dealing with those patients, because the nutritional status plays a major role in establishing the speediness of the heal.
Sorry, I want to echo what's mentioned by Dr. Bukhari, because what's mentioned by you, your experience and experience by Dr. Raymond, is to heal about 70% of the leak. But the refractory to all these measures, which is a 20 to 30%, they come to you after 6 months and they are in bad shape. I think the best solution is to do a laparoscopic esophagogynostomy, Roux-en-Y. And this is my experience in the American University of Beirut, where I had referred from the Arab country about 7 cases, all of them treated successfully by laparoscopic. And these are the chronic cases that is no measures. They have done previously drainage procedure and even enteral feeding. So this is successful only in 70%, but not in 100% of the cases.
If I can
Last
just,
question, please.
if I can just correct something, Dr. Maher, we have not had any patient who required anything else. So
Okay,
we
I'm
had
telling
100%
you what
success
you
rate so
haven't
far.
you have seen in your experience. Please.
Thank you for this presentation. Rodiq Shmali from Lebanon. You all mentioned the surgery, the stent, the conservative management. What about the internal drainage with the pigtail? And what about the dilatation of the incisura or the pylorus, which is the main problem, one of the theory for the high pressure zone, the inferior high pressure zone? What do you?
I think in our series, when we did an endoscopy, we have not encountered a single patient who had either a twist or a stenosis. And our plan is, if that's the case, is to actually convert the patient, like Dr. Walid said, to a Roux gastric bypass. The reason we don't take that first is because it's a difficult operation. Maybe it's not difficult for Dr. Walid, but for me, this is a difficult operation. And I think I probably would not have the same results Walid does have. Your second question is internal drainage with a pigtail catheter. You mean endoscopic drainage? Yes. The reason we do this is because even though we're at a tertiary center, a large hospital, our gastroenterologists are not comfortable putting stents in these. When we approached them, they just told us, listen, I mean, we have no experience with it, we're not comfortable doing it. And that's why we did this. And we have not had any patient where we went to the pylorus and found the pylorus is not normal. We have not dilated the pylorus in any of these patients. And we have not dilated the incisura because none of them actually had a tight area there. All these patients had an endoscope where you can go easily into the pylorus. No kink, no strictures.
Thank
but
you,
I agree with you.
Thank you, Dr. Nayan.
Yeah, thank you.